All right, chapter 25 is all about poisonings and overdose emergencies. So we'll talk about poisonings as well as alcohol and substance abuse, which is very relevant for our communities. So poisoning. A poison is any substance that can harm the body. The harm it can cause can result in a medical emergency. And we do get called quite a lot for different things. Accidental ingestions, I didn't have the cabinet locked and, the baby got in there and ate a whole bunch of random stuff. Or maybe it was a plant or whatnot. Lots of different common things. Essentially anything that's not meant to be eaten, if it's eaten, could be considered a poisoning. So medications, cosmetics, pesticides, plants, foods, petroleum products, all of them. Effects of a poison. Harm to the body is going to be based on the nature of the poison, its concentration, the route of entry, the patient's age, weight, and their health as well. So say we have an infant that eats a couple of berries off of a poinsettia. Well, one, the poison itself, it's not going to kill them right away, right? Typically, it would just give them an upset stomach. But if they ate a couple berries versus a whole plant worth of berries, that definitely would change kind of what the reaction is going to be. Route of entry, was it something that they ate or did they just, rub it on their skin? How old was the patient? Well, a year-old versus 30 years old, it makes a difference as far as what we're going to see symptom-wise. How large was the patient? 20 pounds versus 200 pounds. And then the generalized health. Do they have any other underlying health conditions that could cause potential for concern? Damage to the skin and tissues from contact, oftentimes, especially if this is something that was put on like a patient's skin, like bleach or maybe a powdered chemical. If it gets on the skin, it can certainly cause a lot of damage to that area. Potential for chemical burns, right? Suffocation as well. If it's something that's inhaled, like anhydrous ammonia, it's inhaled, it can cause issues with suffocation. Poisonings are classified by route, so we can have something that's swallowed or ingested, inhaled, absorbed, and injected. Pediatric notes. So typically homes with small children are going to be some form of child-proofed. So, anything toxic may be either put in a locked cabinet or put in a high cabinet, so it's not easily accessible. But that being said, is kids don't always stay in the home that they're being raised in, right? They go visit grandparents or they go visit friends or whatever, and they might come across different areas that aren't child-proof as effectively, and it can have some issues. Ingested poisons. So children may accidentally eat or drink something that's toxic. There's a big issue with Tide Pods there for a while, right? Adults often an accidental or deliberate medication overdose. So it is common that we would be called for a medication overdose. Again, this can certainly be accidental. We never want to, judge a call by its dispatch information, but sometimes it is accidental. Other times it's deliberate. When we start doing our patient assessment, getting information like what substance was involved, getting the exact spelling of that substance, transporting it with the patient to the hospital. Now, we only ever want to transport it with the patient if it's something like, honestly, there's not many times that we would transport it with the patient. Even something like a medication bottle, if you write down the medication or even take a picture of the bottle and give the picture to the hospital, that's sufficient enough. We want to be cognizant or aware of what we're transporting to the hospital so we don't further contaminate the emergency department as well. Okay, so just use some common sense with that. When did the exposure occur? So quick acting poison requires faster treatment. ED personnel need to know the appropriate testing and treatment. Sorry guys, I'm getting my words all twisted tonight. What this is getting at is that depending on what they took, it needs to be, counteracted very quickly. Other things take a lot longer to work, like Tylenol overdoses take a lot longer to actually affect the system. So you can be a little bit not slow with how you treat it, but a lot more methodical and do testing that's required first and so on. Okay, it's not as emergent. Not good, but not as emergent. So how much was ingested? Again, are we dealing with, 5 berries versus 50 berries? Is it, a couple more pills than they were supposed to take, or was it the whole bottle? And getting good, accurate numbers on the amounts that they took. Over how long did the period of ingestion occur? Was this something like they were, taking, they were supposed to take 2 pills and they took 4 pills right away, and then they decided after they took 4 pills they'd take another 4 pills, but it happened over, 8 hours versus, oh, I swallowed the whole bottle in the last 30 minutes. It makes a big difference as far as the treatments. What interventions have been taken already? Oftentimes, patients will try and do, especially if it was an accident, patients will try a home remedy first before they call us. So things like, oh, I tried to get myself to throw up, or I swallowed a whole bunch of castor oil, whatever it was. It's good to kind of have an idea of what they actually were doing to try and help this issue. Patients' weight, estimated weight in EMS and healthcare across the board, we're very bad at estimating patients' weights. Okay, we're very bad at it classically. So instead of just looking at a patient and going, they're about 100 kilograms, we'll actually, ask them, can you tell us how much you weigh, so that we can then get a good, accurate measurement on the patient. Now, I'm completely aware of the fact that not everybody knows how much they weigh, or it may have been, 30 pounds ago that they last checked. We just ask them. They're going to have a better idea on how much they weigh than just us guessing. We only guess when we absolutely need to, like our patient. We need to know, and our patient isn't able to tell us. What symptoms do they have? Nausea, vomiting, altered mental status. What have they experienced? Food poisoning. So this can be caused by improperly handled or prepared food. Signs and symptoms: nausea, vomiting, abdominal cramps, diarrhea, fever. We're going to prevent this by washing hands and surfaces that touch raw meat. Good food preparation before and after cooking things, so that we make sure that everything is good and preserved properly is another one. This is kind of cool. I really enjoy getting into preserving food, whether it's, canning or freezing or whatnot. Drying food, all of that is something that interests me quite a lot. But making sure that it's done properly, especially canning, especially if you're canning things like meat, making sure that it's done appropriately is really important to ensure that there's not additional bacteria that kind of builds up and then causes issues with people later on. So all very, very important stuff. Activated charcoal. So as EMTs, you can give activated charcoal. I will say, and correct me if you, please put in the comments if you work for a service that has activated charcoal on the trucks. But I have yet to see a truck that actually has activated charcoal on it. And I've been going around the county and doing quite a few different refreshers this semester, and none of them so far has had activated charcoal on it. Reason being is that there's very few calls that deal with overdoses, so it's or poisoning. So it is a small percentage of the calls that we deal with, and out of those small percentage of calls that we deal with, it's an even smaller amount of calls that would require or would be benefited by activated charcoal. And of those very few calls, that would be benefited by activated charcoal, the patient also has to be willing to drink this. And it's charcoal. It's a liquid charcoal. So it doesn't taste good. It looks disgusting. It's very visually off-putting. So out of those very few calls where we could actually use this and have it benefit the patients were unlikely to drink it, or would just downright refuse to drink it. So it got taken off of trucks, essentially. Activated charcoal works through absorption, allowing substances to attach to its surface. It's not an antidote, it just prevents or reduces the amount of poison absorbed by the body. Many poisons, but not all, are absorbed by activated charcoal. Medical direction can help you determine whether it's appropriate to use for those specific poisonings, as well as poison control can give you a good idea as well. Contraindications: if your patient's not able to swallow it, if the patient has an altered mental status, if they've ingested any bases or acids, or if they've swallowed any gasoline, you can't use it. Traditionally, syrup of ipecac was what was preferred for treatment. It induces vomiting in most people with one dose. However, it does have a high potential of making people aspirate. So when they're vomiting, they accidentally breathe in some of the vomit. And it only removes about less than 1/3 of the stomach content. So it does leave quite a lot of the stomach contents in the body. Dilution. So adult patients should drink 1 to 2 glasses of water or milk to help dilute, and children should drink 1/2 to 1 full glass of water or milk to help with the dilution. Water may slow absorption, but milk may soothe the stomach, soothe any stomachs that are upset. Frequently advised for patients who are determined by medical direction to not need transport. So if it's a situation where, say, a child ate something that's making their stomach really upset, they deem it, yes, technically that's a poisoning, but, the child's doing fine. They didn't take enough of it to cause any permanent damage. You're on the phone with medical direction and they say, hey, let's try some dilution. If they have milk in the house, let's go with, a full glass of milk that they need to drink. That would be kind of that situation. If we're transporting to the hospital, typically we are not going to recommend that the patient drink anything that's not a medication. Our job in these situations is to detect any life-threatening problems and treat those life-threatening problems, perform assessments, get those baselines, contact medical control as necessary, or medical direction or poison control as necessary, transport the substance information. Again, we want to be very, very picky about what we transport as far as substances. We don't want to cause any additional problems, especially if it's like a chemical where it kind of has fumes or anything. We don't really want to transport those. And then, of course, reassess our patient as we typically would. Antidotes are thought of as a substance that will neutralize the poison or its effects. Very few genuine antidotes actually exist. Naloxone does directly reverse opioid narcotic depressant effects on level of consciousness and respiratory drive. Tylenol poisoning or acetaminophen poisonings. So this is a common cause of overdoses. We do get this a lot for our stereotypical kind of young teenage girls is typically the ones that will get called for on this particular case, but not always, right? Toxic effects don't appear right away. Usually it takes 4 to 12 hours. That's when they start getting kind of a loss of appetite, some nausea, vomiting. 1 to 2 days later, they start getting some pain in their upper abdomen, maybe some jaundice. Tylenol is absorbed or processed in the liver, so that's why you're getting some jaundice that's happening here. And it can cause permanent liver damage as well, but you do have to take quite a lot of it. Pre-hospital assessment and management with acetaminophen poisoning or any overdose, we want to have a high index of suspicion. Why did they take that much? Is this more of a mental health issue, or is this a confusion type issue? We do get a lot of different reasons as to why people took an excess of medication. Sometimes it's they were in a lot of pain and they thought more of that medication would help. Other times they were just really confused. They woke up in the morning at 5 a.m., which was earlier than they typically do, but they woke up at 5 a.m. anyways, and they took their morning pills, and then because it was really early, they went back to bed, and then they woke up at 8 a.m., which is more of their normal time. So then they took their morning pills and then, went about their day, and it's not until a little bit later that they realized, oh my gosh, I took twice the amount of pills that I was supposed to take. We'll sometimes get called in those instances. And oftentimes, if that's the case, we're not just dealing with one thing that they took an additional dose of. It's usually their whole set of morning medications, which can cause, some concern. And it just depends on what they took. Okay. Other words. Other situations that we might get called for are going to be like your classic suicide attempts. Okay. So certainly we want to make sure that we're wearing our standard precautions. Looking around the scene, we're taking note of any medications that were taken. It looks like this particular scene was probably a medication overdose. So we're going to look up the medications by either calling our poison control or medical direction, and then saying how much they took, and what symptoms the patient is feeling. Once we get them into the ambulance, if you have activated charcoal that you can give, and it is recommended in that particular instance, you can give activated charcoal for the patient. Like I said, I would be shocked if you guys actually carried it. It's not very common these days. If you give somebody activated charcoal, you can just about assume that they're probably going to throw that back up. So make sure you have an emesis bag ready to go, as well as suction. You can see this picture, she's got suction nice and handy in the background. Okay. So I think this is actually a part of the assignment for this week, but think about, your own home, or just look around the room that you're sitting in right now. Is it currently safe for a small child? As somebody who has a small child on the way, looking around this room, we got some work to do. Thankfully, the child is still a couple of months away and won't be mobile for at least a little bit, but we got some work to do at the house. All right. So take a look around your home and see if there's anything that would be potentially dangerous or could cause maybe some poisonings for children. Inhaled poisons. So some common types would be carbon monoxide, chlorine gas, ammonia, agricultural chemicals, and carbon dioxide. Any scene that we're approaching, obviously we want to approach it safely, but if there's any inkling that there might be an inhaled poison about, we definitely need to approach with safety. We're using our eyes to look around to see if there's overturned tanker trucks, or if there's a bunch of people that are all experiencing the same symptoms. We should definitely have a high index of suspicion that there's some sort of inhaled poison in the area. Okay. Oftentimes we're not trained specifically in these instances, so it is the appropriate choice to stay away from the scene until the scene is deemed safe via usually the fire department. When we're doing our assessment again, what is the exact substance that was involved? When and how did the exposure occur? How long did it occur? What interventions have been taken? Did somebody remove the patient? Did someone ventilate the area as well? And what effects is the patient experiencing? Carbon monoxide is something we come across. It seems like at least once a winter we'll get a call for carbon monoxide poisoning, or a potential of carbon monoxide poisoning. This is a colorless, odorless, tasteless gas. It can be caused by improper venting of wood-burning stoves, furnaces, and generators. So really new construction or really old construction tends to be where we see some issues. Not always, but generally. Common cause of death during natural disasters and power outages, because people are using things like generators that aren't getting ventilated appropriately. Signs and symptoms of this: headache, especially kind of a band, like a headband around the head, dizziness, difficulty breathing, nausea, cyanosis, altered mental status, and in severe cases, unconsciousness. Yeah. And I think it's state mandatory now. And Mitch, I think you're on tonight, and you probably know a little bit more about that. But I think it's mandatory now that EMS professionals have a carbon monoxide detector with them. I know it got put on all of our monitors, but I know a lot of our jump bags also have them on them now as well. A lot of the services I've gone to for those refreshers, they all have them too. They're just these little kind of boxes that are the CO detectors. Mitch, do you have any comments on that? Are you on? I think you're on. There you are. Oh, your sound is off. I feel like this is always an issue with you, Mitch.
How about now?
You're good. Yep, you're good now. Okay. I'll let you chat for a second.
No, my time at McFarland, we had them on our jump bags, and we've actually came across twice where we went into a home and they alerted. We backed out. There was a reason why they were feeling ill. We were able to get them out of the house, but then it's like, get a fire department response here, and sure enough, um, either it was a malfunctioning water heater or furnace. So and they did not have a CO detector in their home. It was our bag detector that went off. There are several types. Some have to be what they call a bump test every month. There's some though that are pretty much sealed, and they're good for like 10 years. I know the one we had was very specific on how you turned it on. It was cheaper. It just took a AA battery, but you had to go through a process. So full-time staff were the only people that were dealing with it. So that way they were more familiar with it. But they are definitely a good thing to have on your jump bags, because we're going into these people's homes, and like she stated before, it's odorless, it's colorless. It alerts. Maybe we get the family out or whatever, but it could certainly save our staff, our EMTs as well.
Is it required to have one with the EMS services?
I don't know if it's required. I have not heard for sure that it is required, but it is certainly it's certainly more popular and becoming more, I think if it isn't required, it will be soon. I think somebody else asked me about monitors on bags too, because their service was thinking about doing it. So it might be required now, but it's certainly a good, and they're just small. I mean, they're smaller than your cell phone. So, it's just, like I said, I'd have to dig into more to see if they are required. So I think somebody just put something like it was required now.
Yeah, Kelly just mentioned that Brian said that one is required for each squad. I was thinking that there was some sort of legislation that changed, not like within the last year or two, fairly recently, because I know I had never really seen one, and then all of a sudden all of the trucks had them, or all of the monitors had them. It's like, oh, well, that's a good idea.
They're not a
I feel like we
four
should have had
gas
these
per
before.
se. Yeah, they're not a four gas. They're most likely a CO, but they might be able to do others. But it's not going to be the big complicated four gases that fire departments they have.
Yeah. Oh, awesome. Well, thank you for chiming in.
Yeah.
One of the issues that we see with CO, carbon monoxide specifically, is that it actually it messes with our SpO2 sensors. So SpO2s are really, really good at doing one specific thing. And what they do is, I'm gonna pull it up and we're gonna talk about it here. Like I always enjoy doing, we'll draw a little bit here. So if you've got a finger, that's actually a pretty good finger. I'm pretty happy with that. And you've got a SpO2 sensor that you put over the top of the finger, right? The SpO2 sensor is going to send a beam of light through your finger, and it's going to look at all of the blood cells, red blood cells, that are going through that beam of light, okay? And on each red blood cell, there should be, whatever it is, a certain amount of oxygen. And as the oxygen goes through that beam of light, it'll read how much oxygen is on each of those red blood cells. And it'll read it in a percentage. So it's, 80% full, or 90%, or 95, or 100, right? You guys all have seen SpO2 sensors. Well, the issue is that carbon monoxide has a higher affinity to our hemoglobin than oxygen. So what it'll do is it will come in and it will kick off all of the oxygen and sit on those hemoglobin. So when the SpO2 sensor is put on, it'll see that all of this is 100%. Look, because there's 100%. There's 2 on each one. That was exactly how much was on with the oxygen. But in reality, it's not reading the oxygen level. It's reading just how full those receptors are. So this is carbon monoxide versus actual oxygen, right? So we'll get false readings with our SpO2 sensor, which can be a bit problematic. Hold on here. There we go. Back to this. So make sure if you ever do have a patient that's struggling to breathe or having some breathing difficulty, we're still giving them oxygen. In this particular case, they may have that 100% oxygen reading, but we want to make sure that we're giving them large amounts of oxygen to try and flush out their system or wash out their system. Okay. We need to move the patients out of the environment that is unsafe, but we typically are not the ones doing this. Typically, this is going to be trained professionals, usually the fire department, that's going to come in with their respirators on and safely get the patient out of the environment that they're in. Okay, so again, the scene is not safe for us or for our level of training. Now, if you're thinking, well, I've had training. If you've had additional training on how to do that safely, then go ahead and do it. But this class is not giving you that training. All right, you gotta go and get some additional training to do that appropriately. Smoke inhalation. So smoke inhalation is associated with thermal burns as well as the effects of irritants and chemical poisons within the smoke. So substances can burn the skin, irritate the eyes, injure the airway, and progress to respiratory and cardiac arrest as well. So oftentimes when we see smoke inhalation, our patients will experience symptoms like difficulty breathing, coughing, kind of a smoky or chemical smell on their breath, or a black carbon residue in their mouth, nose, or septum, as well as singed nasal hair. So anytime we have a patient that comes out of a situation where there's smoke inhalation involved, usually it's a burning building or something like that, we always want to be on the lookout for these things. That black carbon residue or the singed nasal hair is a fairly straightforward giveaway that they've had some smoke inhalations. And as soon as we can determine that they've had smoke inhalation, we now know that their airway is very unstable and fairly unpredictable. With smoke inhalation, you get those chemical burns or potential for chemical burns. So you have swelling, as well as a potential for airway collapse. So make sure that we're, calling for ALS or really securing that airway appropriately quickly and being very aggressive with our airway treatment to ensure that, our patient still has an airway in a couple minutes. Of course, provide high concentration oxygen transport as well as all of the things that I just said. Okay. Detergent suicide. So this is a method of suicide that was started in Japan, and it's becoming more and more common in the United States. I will say, and again, Mitch, feel free to comment, I haven't seen one of these. Not to say that it isn't common, but I think it is less common than it once was, as far as methods of suicide. What happens is it's two chemicals that are very easily obtained, mixed together to release a toxic chemical called hydrogen sulfide gas, and that gas is what causes I think it's the suffocation of the patient, or the death of the patient. But Mitch, have you seen one of these?